She is an associate professor of clinical psychiatry and the coordinator of the foster care team at Tulane University. Her interests include the influence of early adverse experiences such as maltreatment and institutionalization on child development. And she also has a particular interest in attachment disorders and disturbances in the ways in which caregivers can foster the development of attachment in young children with no prior attachment relationships. And also a New Orleans native or citizen?
No.
Citizen.
There since '87, so
Okay.
almost never a native if you weren't born there.
Fair enough. So also it sounds like you have interest in looking at the fact that traumatic experiences on what they're looking at. So happy to have you.
Okay, thank you very much. So I'm really happy to be here this afternoon, and I do hope that we can have a discussion. I wasn't sure exactly who was going to be here, so I wanted to know who is who and what you're all doing. So let me start with possibly the most important, foster or adoptive parents. Excellent. Okay, I expect you to inform us because you have the hardest job on earth, followed closely by the DCFS workers. Okay, who is a psychologist? Okay, who is a social worker? Great. Who is an adopted person? Okay, great. Who did I leave out?
Adoption professionals.
Adoption professionals? Who is none of those other things but an adoption professional? 1, 2, good. Okay. All right, now who did I leave out? Yes, ma'am.
I'm a student.
A student, okay. How many students in here? Excellent, okay. All right, now who did I leave out? Researchers. None of those other things, okay. I don't want to get going on the Venn diagrams here. Great. Okay, so obviously we have a fairly learned group here. I hope that you will not be insulted by my initial review of attachment. And the reason I'm doing a review on attachment is because attachment disorders should, if we play our cards right, be related to attachment. And a lot of times what's described in the literature, or maybe on the net, as attachment disorders really could fall under a variety of other diagnoses like oppositional disorder and lots of other things like that. So I don't plan to focus too much on that, although on my little stick I have a presentation or some things that address what attachment disorders are sometimes characterized. And I think there was sort of alluding to that this morning with holding therapy and that kind of thing. And of course, most of the people in this room know that coercive behavior towards a traumatized child is usually not recommended, and that's one of the big problems of some of the ways that that's approached. So I'm happy, though, to have a discussion because I think this was first described really in conditions of social deprivation, but not in conditions of nutritional and environmental deprivation. It was first described by Tizard and her colleagues in an orphanage in London where everybody had enough to eat and had lots of stimulation and so that wasn't an issue in the original description of what is attachment disorder. It was the rotating caregivers, many per month. It was the instructions to the caregivers not to get attached to anybody, despite the fact that often they did. And it was the subsequent placement in adoption. If you were a redhead, forget it. You were not put out for adoption because no one would want you in the early 60s in Britain, nor if your parents had any serious mental illness. So obviously our thinking has changed a little bit, but I do want to just sort of put that out there that this was initially, although it certainly can be a sequelae of deprivation, it can be purely social emotional deprivation that causes this too. It's really important to try to tease it all out. So who, raise your hand, will feel very insulted if I go over attachment? Oh, you're very kind. Okay. So we're just going to do what is attachment, how do these attachment relationships develop, how do we assess it, what's a disorder, and how can we intervene in cases of disturbed attachment. I will share with you a little bit of the results that we have from the Bucharest Early Intervention Project, and then we'll sort of proceed from there. Anybody sees this thing sliding right off? Feel free to jump up. Okay.
Connected tighter, that's what was wrong with mine.
Oh, the blue thing, yeah, let's see, it's this thing.
Try to connect.
Yeah. Oh, man, look at that. I know, I knew that's what was going on, but I didn't want to. I think that's going to happen. All right. Okay.
Use the mouse.
Hmm?
Again, the mouse.
Yeah, all right, good plan.
The mouse doesn't work.
Oh, okay.
The mouse doesn't work. It's always something, isn't it, people? It's always something. Okay, so I'm going to be looking back and forth, sorry. Okay, so why does it matter? It matters, of course, because kids need to develop the expectation that they can trust their caregiver and that they will be there for them. It was an interesting discussion with Mary Dozier, and I think this morning when you had the question about how do you develop a sense of beginning to take care of yourself as after the kid has gotten the initial sense of security from the parent. And I think people struggle with that all the time about, you know, am I coddling this baby? And certainly when kids get older, there's always, we have a lot of worry about spoiling in New Orleans. We don't want to spoil anybody by holding them. So the quality of attachment is a predictor for later well-being, particularly in middle childhood and adolescence. And as Mary said this morning, insecure attachment per se, being avoidant, being resistant, being secure, those do not predict psychopathology like disorganized attachment does. It's a relationship construct. Whoever said this morning that you cannot have an attachment disorder without two people was correct. And a lot of times, people will walk in and say, I really don't know why I should have to come for this. Could you kindly fix this child here? Because I don't have time and it's not my responsibility, but you need to fix it. You have to have a developmental level of more than 10 months cognitively. And of course, this can be if you have developmental delay and you're 20 months old and you have severe impairment, you may not be cognitively able to form an attachment yet. And it's possible to look at attachment in the strange situation, which is the gold standard, but it presumes a relationship. And sometimes it is possible, we certainly had strange situation procedures that we did in the Bucharest project, but there were gradations in the level of attachment that the child had experienced with their caregiver, with their institutional or foster caregiver. So this is not new to you that people will say that there's a bond. You know, some people are attached to their children prenatally. Some people are attached to their children when they see that first picture that comes from the orphanage of their child and they're like, oh, this is my child. And so the idea that having seen only the picture that you and knowing something about the kid that you can grow that attachment is really also a testimony to how we as humans nurture our own. And I think that's huge. However, an infant who is 3 weeks old does not have the cognitive ability. They can sure prefer one person or another, but they don't, odor-wise, but they don't have the attachment capability at that young age. So we see attachment behaviors, crying, wanting to be picked up, crawling towards the caregiver, calling from college and saying that you got a C on a paper and you really hoped you were going to get a B+. I mean, those attachment is present across the lifespan. And those of you who have college-age kids know what this is like, that you are still providing that security from a distance. And those of you who are engaged in elder care know that that kind of shifts around a little bit. As they get older, they start to depend on you a little bit more, and you start providing things for them that you are not, but you can certainly become a secure base as your parents age. It's a system and it's a relationship, so it holds lots of different definitions and sometimes different meanings to people. These are, of course, Bowlby's standards, the systems of attachment, exploration, affiliation, and fear wariness. And I ask you to keep these in mind as we have a discussion later about what RAD, indiscriminate sociability, disinhibited, is really about. And I think it's emerging in the literature that this may be a little bit less of an attachment disorder per se, but related to the development of attachment over time and when an attachment relationship. So I assume we'll have a great discussion about that. So I've added in here prenatal and pre-adoption expectations because those of you, I work with foster parents who foster and adopt. I don't work with so many parents who are looking to adopt and just don't go through that foster care system. But I know that just like when a person is bearing a child biologically, that there's an anticipation, there are feelings about what this child is going to be like. Those of you who are familiar with the working model of the child interview know that you can deliver that, you can give that interview to expectant parents and they will tell you all about the child that they are carrying. Obviously never having met the child, but they have certain thoughts about what that child's going to be like. And I don't think it's been done, but somebody could jump on doing the working model of the child interview with people who are awaiting an adoption. Because I think there might be some of those same thoughts and feelings and ideas, sometimes generated from where a person is coming from themselves in terms of their adoption history, that might be very much present for parents who are awaiting an adoption. Of course, in the beginning, there's limited discrimination, but some preferences emerging 2 to 7 months. And then there is, of course, when kids develop a focused attachment, a hierarchy, signaled by stranger wariness, which is, of course, missing in kids or dampened in kids who have indiscriminate behavior, and then separation anxiety. Secure base behavior, 12 to 20 months, and then goal-corrected partnership. So, how many of you are familiar with circle security? Okay, good, because that is such a fine framework for thinking about what things look like, and I think it's very helpful. But, of course, as exploration is up, attachment behaviors are down. When attachment behaviors go up because the kid is distressed, then exploration goes down. I'm not telling you anything you don't know about why we need attachment. Back to the monkeys that were written about. There's a fascinating book about how they developed that research, and definitely preferring a warm caregiver even to food. Being close to an attachment figure reassures the child, especially for kids exposed to expectable rearing environments. And these attachment patterns do not emerge from the child. They are based on the history that the child has with the parent. So if a child is not used to receiving comfort from a parent when they have a little distress, they know that if they go by the parent, close but not too close, they will get reassured. And that's basically what we see in an avoidant relationship. How many of you have watched Strange Situation Procedures? Good, so a goodly number of you, probably half or so. So it's supposed to be mildly stressful. Every once in a while, somebody runs the separation for 3 minutes when the kid started crying at 2 seconds, and it becomes more than mildly stressful. But basically, this is what we have as the gold standard for looking at attachment, but it very much assumes that there is a fully developed attachment relationship present. And as many of you know, that's not always true. So basically, my caregiver is okay with my scary feelings and helps me feel better is sort of the definition of a secure attachment. And so when a child is hurt or afraid, when the parent meets that need, then the child learns that they're there and they can go for longer periods of time, help to reassure themselves, and basically have return to exploration. When negative feelings are not okay for a caregiver, except in the most extreme of circumstances, because avoidant parents will generally downplay small distresses, but are definitely present if a kid is sick or will take action, something like that, when it looks like a bar has been met. And I think that's kind of a individual for each parent. But kids really learn very quickly, and interestingly, by the age of 10 to 12 months. I mean, usually do a strange situation earliest at 12 months. The kids have gotten, okay, this is okay and this is not okay, which is pretty perceptive, and it's a complex system for kids to have learned in that period of time. Nonetheless, they are able to get reassured by being near their caregiver. So for kids who are resistant, ambivalent, and most of these apply right to little kids, let's say 12 to 20 months, something like that. This looks a little different in children who are older. But resistant kids show lots of negative affect or passivity in the presence of the parent, and they are of course held by the parent but not really comforted. The focus is really on attachment behaviors and not on exploration. So I know you probably have all seen parents in a strange situation who will say, I'm leaving now, I'm going, I'm about to go out the door now, I'm leaving now, and really appear to want to rev the kid up. And it usually works pretty well, so that that dance is, by the time that parent has left the room, that the kid is in pieces, and then stays very, very distressed until the parent comes back in, and yet can't really receive comfort from the parent because they stay very close to the parent, but they can't receive comfort from the parent. So that child really focuses on needing comfort, but never quite receives it. And a lot of times, particularly in the circle security model, if a child does go out and explore, the parent feels rejected or abandoned. So there's a lot of pressure on the child not to go out and explore. Okay, so really the fascinating thing in this process is that the child has figured out how to feel protected by the parent, really in a very short period of time. Based on the history with the parent, kids know what their parents are going to do. They don't expect the parents to do something out of character. And whether the relationship is secure or insecure, it is not associated with psychopathology. And I think back in the day, we used to worry about whether, if you have an insecure attachment, what does that mean? What we have come to find out is that organization of the attachment relationship is the thing that you really are concerned about. But then there are disorganized attachment relationships. And this is 15 to 20% of middle class, samples, sort of expectable environment samples. When Mary was talking this morning about frightening behavior, a lot of times for these parents who are disorganized, it's very transitory frightening behaviors. So that they might be sitting there with the kid and playing, And then all of a sudden they're like, and they look really afraid, and the kid's like, what? And why are you afraid of me? And then it goes. Very, very transitory. And so the parent may have thought of something that frightened them. They may, sometimes in domestically violent relationships, you'll see that parents have got a little boy, a 15-month-old boy. He's so aggressive with me. He's just so they have got that fear of that child confused with their fear of the child's parent. Sometimes they look afraid of the child, and sometimes they look very aggressive towards the child, and that's also very scary, because this is my person who I'm supposed to be able to count on, and if I'm afraid, I get to go to this person, but this person is scaring me. So what do? And that's why you see the freezing, that's why you see the fearful expressions and that kind of thing in disorganized attachment. So obviously, rates of disorganization are very high among children who have had maltreatment or children who are in institutional care. We had in the Bucharest baseline assessments of SSPs with preferred caregiver, we had 78% of our kids who were disorganized in their relationships with their caregivers. Now, the other 20+% were secure. Now, that sounds kind of peculiar, doesn't it? Because you wouldn't expect that in an institutional setting. You know, one lady comes on Tuesday during the day, her schedule's Wednesday at night, Thursday at night, and then she'll be there Sunday to fill in for somebody else. So that kind of, and I may prefer her, but too bad about me because I get to see her twice a week. And that's the kind of thing that is so dysregulating for kids. So y'all know this already, that affective communication errors, a lot of expressed emotion, role reversal. I know you see a lot of role reversal. And intrusiveness and negativity are all adult behaviors that are associated with disorganization. So this is from our Bucharest project, and this is Betty Carlson, who is a flat-out genius. And she, of course, does a lot of training on disorganization and coding disorganization. So she took our videotapes of our kids and coded our strange situations. And what she came up with was, okay, and I will say happily that the distribution of attachment classifications in the Romanian population of non-institutionalized children was pretty much equivalent to what it is among other populations, US, German, other types of populations like that. So that's always happy news when you're doing a measure someplace else and you're not sure if it's really going to fit with the culture, and then it does. Sort of more support for some of these concepts being human concepts, not as culture bound. But what Betty did when she looked at these videos was to try and get an idea about sort of the degree to which an attachment had been formed. Because, of course, it's possible to look securely attached with a stranger if you're indiscriminately social. And so what she saw in our group was every kid in the never institutionalized group had one of the traditional attachment classifications. So that's, you know, either avoidant or resistant or secure or disorganized. Those as the traditional, the traditional classifications. Among the children who had had institutional experience, she saw some other patterns which were really very interesting and helped us in our thinking about attachment in the strange situation used with that population. So she might see a traditional pattern, but she also might see unusual behaviors. And so a caregiver would come back in, the child would clearly be relieved to see the caregiver, but would be doing a stereotypy. And clearly the child was using that for some kind of emotion regulation and not able to approach the caregiver and get the kind of comfort that they needed from the caregiver. Or the kid would be running around like a little tornado, still very, very dysregulated and not able to get that comfort from the caregiver. Kids who were rated a 3 were somewhat passive. They had a clear preference for the caregiver over a stranger, but they showed some distress but very little search behavior where the kids go up and look and bang on the door. Kids rated a 2 had a slight preference for the caregiver, but little affect or search behavior. And then kids rated 1 basically showed no attachment behavior and no differentiation between the caregiver and the stranger. And this is in the Zena et al. 2005. So these are all the behaviors that can be used to look at attachment outside necessarily of the strange situation procedure. So let's move to reactive attachment disorder. Any comments or questions on that sort of brief little survey? So I really we think about attachment disorders in the context of attachment. So if I see, a child who's distressed and runs to the caregiver and stands by them, then I'm not going to be thinking attachment disorder so much. Now, if that same child is sitting there and comes up to me and wants to sit on my lap, then I'm going to worry about indiscriminate behavior. And some other people might be saying, well, that kid has an attachment disorder. Early indications were that people didn't think it would be possible to have an attachment relationship if you were still indiscriminate. And I think we're seeing that that's actually kind of separating out. So these 2 patterns were first described by Tizard and her colleagues in, she has her 1977 book, and it's been a while. It's been 30 plus years, 40 years. And it was a relatively small group. Considering what it's kind of spawned, it was a relatively small group that she was working with. So for emotionally withdrawn or inhibited children, in this pattern, there was an absence of a tendency to either initiate or respond to social interactions, some inhibited or hypervigilant behavior, and very ambivalent reactions. For the indiscriminately social pattern, there was a lack of selectivity in seeking comfort, support, interaction, and kids were seen as overly friendly and superficially attached. So what this looks like in the institution is really interesting, and it's one of the important things that I was able to experience as part of the Bucharest project. Because we were sent over to sort of set it up. We did our first strange situation at 3 in the morning and called New Orleans to tell them. We're very excited. It's kind of hard to do. But in the institution, the kids, when they're all sort of around, one kid might be sitting off to one side rocking. Really, when they serve the food, might not come up. When other kids go near them and smack them, might cry and then sort of go back and sit against the wall, but not really go to any of the caregivers. And in our experience, when we were first observing, there might be 30 kids with 3 caregivers. So it's a ratio of 10 to 1, which is of course horrible, but it was still 10 to 1. But 30 kids and 3 caregivers is very different from one caregiver and 10 kids, because nobody's got responsibility for anybody. Our experience with kids who were indiscriminate was not that they were particularly social. They might come up, they might smile, they might just as readily I had my glasses knocked off, kids were pulling on my camera bag. So there was aggression sometimes associated with it. And so calling that sort of social behavior it doesn't fit as well. Coming up touching people that they don't know, that kind of thing, strikes me as more of what fits my definition of indiscriminate behavior. You know, sometimes people say, oh yeah, he's indiscriminate, he talks to people from the grocery cart. And I don't know, show of hands on who thinks talking to people from the grocery cart is indiscriminate. No, okay. Just very high level audience. Because it, you know, it's some kids are social. You know, it's tough. Some kids are social. So, but it's the going up, wanting to be picked up, carried off by people, that kind of thing, which I think brings the most worry to parents and also feels the most indiscriminate to us. But in terms, people have talked about the adaptiveness, you know, in the orphanage it's adaptive to go up to people. And it may be if kids are craving interaction, but it has definitely a maladaptive quality to it. The other thing about things like stereotypes, at least for the kids there, going up and interacting with a kid was enough to stop the stereotype. It really wasn't something that they had to do all the time. They were doing it when they were frustrated, so some sense of emotion regulation with the stereotypes. And then also when they were bored. And if you walked up to, which happened really frequently, so if you walked up to a kid and were willing to play with them or something like that, the stereotype is gone like that. And then when you said, okay, well I have to go, then the kid might go back and start doing stereotypes again. So really a lot of thought about what those stereotypes mean. I know for some kids, you know, we think of them as associated with the quasi-autistic pattern, and definitely yes. But then there are other kids who are doing those behaviors and they tend to go down fairly quickly, or it seems like they tend to go down fairly quickly once they start getting regular interactions with folks. And that was what we found in our parent report too. So, of course, markedly disturbed, developmentally inappropriate social relatedness in most contexts before the age of 5. Back in the day in DSM-3, the criteria were that it had to start before age 8 months. Now that's a problem because kids don't have the cognitive ability to form attachments prior to 10 months. So fortunately it's sort of adapted to be more developmentally appropriate as time has gone on. So again, with the absence of the ability to initiate or respond, and also that what we see is not accounted for solely by developmental delay or by something like PDD. So one of the criteria is pathogenic care, and one of the problems with that is that people tend to say the child had foster care or was adopted, hence they had pathogenic care, hence they have reactive attachment disorder. And really every child who's ever had an adoption or a foster care experience does not carry this diagnosis. And it is really tempting for people to put this diagnosis on kids, and we really tend to be more reserved about that. And I'm sure in your practice you're noticing, you may be noticing some tendency to just slap that diagnosis on kids rather than really trying to understand what's going on here, which systems are being impacted. Of course, if a child goes from primary caregiver to primary caregiver, after a while they're going to be like, you know what, I'm not going to try with you. And that makes all kinds of sense. So a lot of times caregivers have to reach out and make an active choice to provide comfort or to provide interaction. And there is the assumption that the symptoms of RAD come from this pathogenic care. So when kids have the absence of a preferred attachment figure, show odd behavior in place of it, or emotional constriction, then we tend to think of RAD, emotionally withdrawn, inhibited. And you're familiar with these. How many people have seen cases of RAD, emotionally withdrawn, inhibited? Okay. So relatively few. How soon after adoption? Say it again?
Fairly soon.
Fairly soon, okay.
Fairly soon, but it was, I mean, it could be seen in the previous, it wasn't it was a foster care
Yeah.
kid with familiar
Yeah.
placements.
Yeah, yeah. Well, you know, in the literature, there's relatively few. We saw this in the institution and we saw it afterwards, so we have some evidence of it, but, you know, Rutter's group and other folks have really not seen much evidence of it. Not of indiscriminate sociability. How many people have seen indiscriminate sociability? Yeah. So that seems to be much more present. Okay. So readily identifiable in samples of foster kids and samples of institutionalized kids, and it really does persist. It's sometimes one of the last things that goes away if you can get it even to go away. And it can be seen in kids with and without preferred attachment figures. So we went, Charlie Zena and I went over to an orphanage in 1999 and spent time talking to caregivers and observing kids and asking them about what they were seeing in the kids there in their orphanages. And we were lucky because they had the general pavilion where there were a lot of kids at one time, and they had done one pavilion, dividing it so that the caregivers, there were 4 caregivers assigned to every 10 children. Now, they weren't there all the time, heaven forbid. They were, only those 4 caregivers would take care of those children. So they were the squirrels, they were the little bears, so they each had a little identity, each of these groups, and they pretty much spent all their time together. And those little groups had many lower symptoms of attachment disorders than did the kids who were in the pavilions when we talked to the caregivers. And we asked specifically about symptoms that we thought were present in the different types of attachment disorders. This interview is probably most appropriate for the first 5 years of life because I think indiscriminate behavior, for example, looks different in school-age kids, looks different in teenagers, and looks different in adults. So you may have school-age kids who aren't quite sure how to interact with peers, who might come up, might be socially awkward and not sure quite how to enter into a conversation. As I know some of the work that they did, again, in the 70s was looking at teenagers, and they had difficulty choosing good post-institutionalized kids, had difficulty making good choices about who they were going to interact with in terms of their peers. And has anyone ever worked with an adult who just kind of comes up to everybody and talks to folks even if they haven't been, and is continually disappointed that people are not their best friend? And I often just look and say, what was it like for you when you were, I'm just wondering if that is a person who has grown up and is still showing some of those indiscriminate behaviors. That's just my own observations. So we ask about all these things, a preferred attachment figure, seeking comfort. So a lot of times our foster parents will say, he comes to me for food all the time. That, in our book, doesn't count necessarily as being an attachment figure. We want to know if they really have a preference to that person, if there's a hierarchy on the list. A hierarchy of the list. Okay, does the child go to the caregiver for comfort when they're hurt? Does the child sit where she is? Does the child go to strangers for comfort? And how does the child respond when offered comfort? Does the child interact and talk back and forth with the caregiver? Or do they tend not to interact and to sit off by themselves? It's not real common with our foster kids to see this, but when you see it, it's quite compelling. The child usually sits there quietly in the foster caregiver's arms, and they'll be like, look, this is how she is. And they really often will feel rejected by the child's behavior and really not be willing to reach out and go after the child, because a lot of these kids, you have to go after them, you know, somewhat, like Mary was saying this morning, you have got to offer it even if they're indicating that they don't want it. You've got to be near them and start to teach them that, that you're available. But people do respond like, well, she doesn't need me, she's just sort of sitting there. And then what is the child's mood like? Is she generally happy or sad or serious or withdrawn? I'm going to attempt to play a little bit of our interview. This is Charlie Zena interviewing a foster mom. Let's see how this works. And it's not going to work. So it's actually not clicking, although I have it in the, let's see. Okay. Well, I could act it out, but basically what he does is ask the caregiver, darn it, you know how you're supposed to put them in the same file and all that, and then they're supposed to work? All right, I'm just gonna go for it. I might not do it on all of these, but. It doesn't work now, then I don't know what to say. Volume is up. Well, what Charlie is saying to this lady is, does he share back and forth with you and tell you a little bit about his day? Does he, can you tell when he's excited about something? And she said, no, not really. He doesn't really do that. And he says, well, what is his mood like? And she said, he is usually sad and serious. I don't see him smiling. I don't see him very happy. She went on to explain, really this kid had RID, emotionally withdrawn. He was about 3, and he had been moved from his grandmother's house, and he was one of 7 in the foster home. And we were a little worried about his opportunity to form an attachment in this group of 7, and so we moved him, and he was able to form an attachment fairly quickly with his next caregiver. This is a very addressable situation if you can get the right match, and we characterize it for our DCFS people as an attachment emergency. If a kid has been someplace for a month or 6 weeks and has not started laying down these, the ability to rely on their caregiver, we really think carefully about it, because that should not be. They should be able to start developing that. Questions? No? Okay.
Actually, I do have a question.
Please.
I'm curious what you noticed about, is there something you found in the parents where that would happen? In the
Oh, that's an
placement?
interesting question. Well,
Or was it
whenever
just
somebody tells me they've had 200 foster kids with pride, I always start to get nervous. And that's just because I'm really worried about. So we have what we call respite foster care, which can go on for a year, where the kid's getting babysat, and is completely inappropriate for little kids, and is probably inappropriate for big kids, but we focus on little kids. And then we have child-focused foster care, where we ask the foster parents to treat the kid as their own and to take on the emotional risk that is inherent in foster care, which is why I think it's such a hard job. The adult puts themselves out there for the kid, takes the emotional risk in connecting to the kid, that the child might be moved, or that a relative might show up, or something might happen. So one of the risk factors is, for me anyway, and I'm totally, if there's anybody in here who's had 300 kids, I apologize, but for me, I wonder sometimes about folks, because it's like, okay, yeah, he's gone, all right, and that doesn't work for little kids. I mean, their primary job is to form an attachment. So if you are in an environment where you can't, it's a huge developmental issue for a little kid. You know, it's hard. It's a hard job. We ask them to meet developmental needs as well as, say
The
again?
audio?
Did I get it to work?
Do you want me to get to it?
Sure.
Yeah.
Why not? That's okay. So anyway, that's one thing that I think, we have people who are family building, and they tend to be speak out of turn here. They tend to be more complex for the agency to manage because they have feelings about the kids and they don't want the kids to be removed. So we'll say something like, they'll be, oh, people are adopting, or people are family building. And we'll say, yeah, so they're a little more difficult because they have feelings and they'll tell you about it, but for the kid, it's great because they've got somebody devoted to them, and that's what you want. So it's, yeah.
So I would wonder, in some cases, it's probably pretty obvious that the parent is not available to the child, that it's not moving forward. But I would wonder if there are other cases where the parent really is trying to make themselves available, and it's more of an issue of fit or chemistry or something else, mismatch somehow.
Well, it's always a mismatch. Like if it doesn't, because that person may have had incredible success with another kid.
Mhm.
So it is always a mismatch. And, you know, like the caregivers in the orphanage will say, I love this one. Oh, I can take her or leave this one. Well, why is that? But there's just something about how a kid clicks. We've had parents who were fabulous with special needs kids and just didn't do well with active little kids who were running all over the place. So it is always about fit. We have some folks who really still get schooled in not becoming attached to the kids. And of course it drives us crazy, but their agencies are telling them, well, you know, and that's very frustrating for us. So the kids that I've seen who have done this lately, and it's been very few, it has been folks who are, you know, who are being told don't attach. And, you know, you can tell some people don't attach and it'll be like, okay, whatever, and they attach. But this person particularly that I'm thinking about was not open to intervention about how she might go after this kid and work to become an attachment figure, which is sometimes necessary for kids. So. Other questions, comments? Yeah.
I'm just wondering if you could tell what percentage of the population actually would be appropriately diagnosed with reactive attachment disorder? Because I think you made a great point that especially folks who don't have a lot of experience with work, peer adoption, foster care, relationship issues equals RAD. So I'm just wondering if you could clarify what's the real percentage of people who would really have that diagnosis or symptoms that would lead you to that?
I'm going to turn to Mary Dozier and ask her to answer that question.
I have no idea.
The literature's not out there. There is so much disagreement
Yeah.
about this diagnosis. This is rare. This is rare. Every child in foster care and adoption should not be getting this diagnosis. But there, so I'm sorry. You know, I can't say
Well, I
to
think
you.
just saying rare is good.
Yeah, it's rare. It should be rare. It should be.
And then I have one other question.
Yeah.
And this might be a question for Mary too, about what can we do to infuse foster parent, adoptive parent education with information that you get from research, not about, like you just said, you know, don't attach to this kid, that's not gonna happen for a lot of people, or they say, okay, they told me not to attach, but really about how you appropriately build relationship skills for children that can lead to healthier attachments.
Well, it's a
we
great.
don't do a lot of that.
Yeah, it's tough because it's almost. So if you are out trying to recruit foster parents and you're trying to say, I have a great idea. How about if you take care of a child who may or may not get removed from you, and a relative may come up at 12 months and say that they want the kid, and we want you to be the psychological parent, and it's a really complicated thing to ask people to do. And so yes, I'm sure there's training, but you know, it makes more sense to do what Mary is doing, where you're doing it in situ with one kid in front of you who you are trying to learn that kid, than it does to give lectures at training about, you know, we're gonna really want you to attach the kid. It's like an abstract versus I got this baby right in front of me, I got this 4-year-old right in front of me, what am I gonna do? So I agree with you that training is important. I think almost child-specific training is really important. But you know, nobody pays attention to foster parents until something goes wrong. And probably the time to take care of it is before anything ever went wrong, to build that relationship before you're, get this kid out of my house. Because our foster parents who say, get this kid out of my house, can be given extra board, training, support, etc., but the kid is gone. It's just a matter of when. I've never, my record is complete, never had a foster parent asked, verbalized to have a kid removed, and then ultimately did not have the kid removed. So y'all may have better luck with that, but we haven't. But you know, it's rare. So this is just a review of the Bucharest project. Data. So this is our caregiver report of signs of reactive attachment disorder, emotionally. Okay. Yeah, we're fine. Thank you. Emotionally withdrawn, inhibited. So you can see that the diamonds are the care as usual. This is a randomized controlled trial, and the idea of it was to ameliorate the effects of institutionalization in Romania. So we got foster parents from Romania. We had 56 homes, and we had about 136 kids who had been initially who were institutionalized pretty close to birth, if not coming from the maternity hospital basement over to the institution. And what we did was did the interview with caregivers or with foster parents, and what you can see is that the triangles at the bottom are the never institutionalized kids. So those kids across time from baseline, which was 6 to 29 months, up through 8 years, had very few symptoms or signs of reactive attachment, emotionally withdrawn. What you can see is that the two groups prior to randomization really had the same number of signs of emotionally withdrawn RID. And then the kids who went into foster care, it disappeared very, very quickly. And the 30 months is sort of the time after which the the foster care kids and the kids who were never institutionalized just sort of tracked along. So, and then for the kids who are remaining in the institution, some were switched around, some went to their family's house with or without the families being happy about it. Some went to government foster care after a while. But those kids in general tended to have more signs of this type of RAD. Not necessarily doing, oh, these kids had RAD or didn't have it, but signs of it throughout the study. And I think we're trying to look at it, sort of getting the sense that it may look a little different by 12 years. They're starting the 12-year assessment now, so there's a more complicated set of evals at this point. So basically, the reason that Rutter's group and that other folks have not seen this is that it really goes away pretty quickly. And so by the time you start, we saw it initially in the institution, but by the time you get kids and families, it should go away. That's why if I still see it in a foster kid, then I will act pretty quickly, assuming it's a fit problem, and try to get the kid into a place where they can establish a relationship. So the questions that we ask about for indiscriminately social are wandering off without checking back, lack of reticence around strangers, and then willingly going off with a stranger. Okay, let's just see if we fix it. Okay, so bad luck. Anyway. So this is a kid who wanders off without looking back. That he is placed in the home. Within the first 2 weeks, he would just wander off and go to people, but by a month, his indiscriminate behavior had dropped out completely. So we're having a big discussion now about whether attachment disruption leads to indiscriminate behavior, which then calms down after the kid gets in a more in a more appropriate environment. So far, Charlie's been telling me there's nothing in the literature, and so we need to write it up. So anyway, we ask about this. We ask about whether the child approaches strangers, and the bar for me is that they touch a stranger. So, going up, talking to somebody, standing next to your caregiver and talking to somebody, I don't think of those as so much indiscriminate behavior. For me, if you go up and you want to sit in somebody's lap that you have never met before, that's a problem. And then, of course, going off with a stranger. This is tough, though, because I'm sure you guys have all your foster parents taking all your kids to all their appointments, but we regularly send a van over. So 2 ladies that they don't know come and pick them up and take them to an appointment and then take them back. So we're trying to teach reduction in indiscriminate behaviors, but we do things that are indiscriminate. Okay, so as you see, with some things, there's not complete resolution from our intervention. So this is a pattern that we've seen where the never institutionalized kids have very few symptoms, the foster kids have more than those kids, and the care as usual kids have the most evidence of that. This was true with cognitive recovery also, that the foster kids were in the middle, the care as usual had poor cognitive scores, and the never institutionalized kids were smack at normal. But it tracks, there's some differences, but as you see, it really stays relatively elevated compared to the never institutionalized children.
A quick question.
Sure.
So, but why for the kids that are still institutionalized and don't get the intervention, they're still going down in symptoms?
Yeah.
Do you have?
Good question. See, that's why I'm a little worried that our interview, as we have it constructed right now, as the kids get older, is not tapping what's actually more indiscriminate behavior at, for example, at 8 years. So I'm not, I feel like it's really going to show up in the peer interaction at 8 years. So I don't know, Jen, if you've heard anything about that, but I feel like that's where it's going to show up, is that difficulty, that social engagement difficulty. I think that's where it's going to show up.
So, yeah.
Not sure.
Well, right, because as kids get older, they should be able to be doing, talking to strangers more and going, and doing more things. So I would imagine it would,
Yeah.
developmentally it would look different, but I don't know how to.
Well, we had a behavioral observation, which it's called stranger at the door. And with stranger at the door, an RA comes to the door, that this is prearranged with the caregiver, comes to the door and says, "Hello, come with me, I have a surprise." And the coding is, did the child say, "All right, let me get my shoes," or did the child say, "I'm not going," or, did the child sort of hesitate and wasn't sure? And then the RA would go with the child around the corner, and there would be another RA that they already knew, and they would talk. So they wanted to see how likely kids were to just sort of go off. And what they found was that some kids were like, "No way," and other kids, including kids in the community, who were like, "Let me get my shoes." So we're not sure what that's exactly telling us about that kind of invitation, what kids are doing at the age of 8, whether it's more expectable that you would go off and explore something, whether if your mother doesn't say, no way, you're not leaving, that you assume you have permission to go. So we're still working on this construct at school age and beyond. So, but your point's well taken. So, you know, again, this is really Charlie Zena's work. I'm not going to lay claim to it. But the fact that there is this the fact that there is this difference in what appears to be attachment disorder at this point. So the emotionally withdrawn, inhibited actually is related to attachment behavior. The kids are not going to people that they should for comfort. They're not readily comforted. They can't regulate emotions, that kind of thing. Looks to be standing firm as an actual attachment disorder. Indiscriminate behavior, indiscriminate sociability, on the other hand, really looks to be more, or it may be, and this is where hopefully we'll have a little bit of time, where it may be more that it's a social communication process. You know, how do I read what I'm supposed to do now? Like, how do I understand what's expected of me? And, you know, those of you who have kids who are 4, 6, 7 months old, 4 to 6 months old, you know the world is their oyster. Like, they will talk to anybody. They're so delighted to talk to anybody. But then focus attachment kicks in, and it's like, you know what, I have no interest in you. And sometimes bio parents will complain, well, last month they weren't doing this. Well, that's because they've developed a focused attachment in that period of time. So it may be possible that the system responsible for affiliation or for social interaction gets kind of tamped down by the formation of an attachment relationship at an expectable time. However, if you're in the institution and you do not have an attachment relationship to decrease that social behavior, then it is possible that that social interaction of just interacting with anybody may keep going over time. It's co-related. It would be, you'd think of it as co-related with attachment, but not necessarily per se an attachment disorder. Okay, what do you think? Does anybody have any thoughts or opinions on that? Yeah.
I think that sometimes with kids living in institutional care, that they learn that by being friendly, I mean, not at 6 months, but a little bit older probably, but by being friendly, by being outgoing, they get a little more. Maybe they get a little more hug, a little more this, a little more food, a little more something. So I often wonder if it's somewhat of a learned behavior for some of these children, that, you know, if I am a little bit more outgoing, life could actually be a little bit better for me.
But does it feel like an attachment disorder? I mean, that's the question. I mean, the question is it an attachment disorder?
I don't think necessarily in those cases it's an attachment disorder. I think it's that they need to have their needs met, and they're getting them met by more than one person, and that's working for them. And
Or they're not getting their needs. I mean, it's
right, or the opposite, right.
Yeah.
So, but I think that if those children end up being adopted, I think that they can start to discriminate and figure out, you know, yes, I want to get these things from mom or dad, I'm not going to get them from the strange lady down the street.
except a lot of times the kids will have a focused attachment with a caregiver secure, and the indiscriminate behavior persists. Yeah.
My feeling is, you know, is it a disorder? Well, the question I think becomes, on your 12-year-olds, when you're looking at them, are you going to see this group is going to have the early sexual debuts? Is this the group that's going to be the on-purpose teen parents?
Because they may not have good judgment about who's a good person to interact with or not.
And that makes all the sense in the world when you are looking at the sequelae of adolescence, of this stuff that seems in latency to be tamped down, for lack of a better word, and then all hell breaks loose when they, you know, hit middle school for a variety of reasons,
Good.
for whatever. But I think that some of your, is it pathological? You'll find out. Next
Well,
time.
parents worry about it though. Like, they'll be like, yeah, she never met a stranger. You'd be like, so, how is that? And they'll be like, well, I'm a little worried, because they go up to anybody. And so some parents are very happy because their kid's so friendly and they really value it. And other parents see the exact same behavior and are very concerned about what it means for the kid and for safety. Let me scoot through a couple of these things. If you had poor cognitive abilities in the care as usual group, you ended up having more symptoms of emotionally withdrawn, inhibited. That was not true in the foster care group. So the foster care as an intervention worked to get rid of that particular set of symptoms well. Age of placement before or after 24 months in foster care helped a little bit, but certainly wasn't, it wasn't like kids under 24 months, they were just no indiscriminate behavior at all. So it's partially remediated, but not entirely. Okay, so here's the biological models that are able to split out secure attachment from indiscriminate behavior. So kids with Williams syndromes, you know Williams syndrome? It's the most interesting syndrome. It's a little microdeletion. I don't remember which chromosome it's on. Little microdeletion. It can go along with lowered cognitive abilities, cocktail chatter speech, so that the kids are thought to have good verbal abilities, but it's actually in terms of having a conversation, they're not as good. They can talk. They have very poor visual spatial performance. These kids will go to anybody at any time. They are securely attached to their parents. They have not had poor rearing environments, but they are attracted by faces, and reportedly, if you go to a Williams syndrome meeting where all the families are together, the kids are just out and about. So it's really, really interesting because it's a split of this indiscriminate behavior. They rank very high on the disturbances of attachment interview for indiscriminate behavior, and yet they're securely attached, or they're attached. So it's a really interesting sort of biological model for the splitting off of these two systems. And then kids with fetal alcohol syndrome are also reported to have more incidents of indiscriminate behavior, although you would wonder a little bit, is that because they're participating in the child welfare system, and it may be moving around a lot is impacting that. Okay, so this is just all the things we want to know. If the child doesn't have an attachment figure, we get them one immediately. Okay, so this is my acknowledgements. Charlie Zena, Nathan Fox, who used to be, as Mary said this morning, totally gets attachment. Now we just can't shut him up about attachment. Chuck Nelson, and then my colleagues at Tulane, Mary Margaret Gleason and Stacy Drury, and then Veronica Proaspatu, who's one of the social workers, terrific social worker over at in Romania. And then, of course, children and families of the BEIP, and also the Tulane Infant Team, who just school us on a regular basis on these kind of issues. So questions, comments? If you want a copy of this, please write me and just ask, and I'll send it to you. I didn't put it on the DVD. Yes?
I just have a question about, has anybody looked at the role of executive function or impulsivity around kids who display these behaviors, or
Yes.
how does that play into it?
Well, Phil Fisher and his team looked at that, and they think that this is related to inhibitory control. Now, that's interesting. And then Karen Lyons-Ruth is doing, looking at indiscriminate behavior in the context of the stranger, and she's rating that, the level of, in the strange situation procedure. So both of those folks are looking at that, at those behaviors. So, and I think there's a little discussion about whether it's inhibitory control or not. It's really emerging, which is kind of fun, to just see how the ideas come along. Yes?
I'm wondering what kind of intervention you do with the foster parents, if any, when the children get placed in foster care?
Okay, so it depends. When we have kids who are showing indiscriminate behavior, we will counsel the foster parents to not allow anybody to pick up the child and to say, oh, we're working on that, and go get the child and bring them back and not let them sort of run off and that kind of thing. It's hard, right? Because we had to tell our social workers in Romania, do not pick up the kids when they ask you to pick them up. Now that's our thought is turn them back around and head them to their caregiver that they're trying to establish a relationship with. Anybody else have any things that they do when kids are showing indiscriminate behavior? Jill, do you have kids who are showing these kind of behaviors?
We do have some
Uh-huh.
things like this. And basically we do the same thing. The focus is on trying to build the attachment relationship with the caregiver.
Right. People will take the kids to church and everybody wants to hold them, and we're like, okay, you know, we know everybody wants to hold your child, and we know you want to have a barbecue with 300 of your relatives because the kid is there, but please keep the exposure, you know, and we don't want the kids, you know, we have the same thing with kids going into daycare within, you know, too short a period of time when they're trying to establish relationships. But we will say, you know, really, we don't want this kid raised by committee. 3 or 4 of you all is enough to be attachment figures for the child. We don't want them taken from place to place and having a little committee raising the kid.
What about other interventions? I'm just wondering in general how you train foster parents, or if you do.
Well, our foster parents come to us already chosen by the agency. And so, you know, some people will do circle of security with, some people, we don't usually do child parent psychotherapy with them because we're not supposed to be treating the foster parents, even though our foster parents come with issues. We had a little family the other day that the lady had lost her own child when the child was 6 years old. And we had 2 kids who had lost their mother, she'd been killed. And they were like, I lost my own daughter, she was killed, she died, and now I have these 2, and the kids are right there. And we're like, okay, this isn't working out. You know, it's just like, there's a lot of grief and loss from a lot of different areas that affect people who are involved in the system, not the least of which is child protection, and also the talking about secondary trauma today, absolutely. So we really try to be aware of that. We don't usually do treatment for all foster parents, but we have done PCI, parent-child interaction therapy with foster parents. I talk to all the foster parents as part of the training for a half an hour to orient them to small kids and to infant team. And I tell them if they, you know, if they feel like they need to babysit kids for a year, then please don't take small kids. It's not unfair because they shouldn't be, if they're going to babysit kids, they shouldn't be taking the big kids either, but anyway. So it depends. We try to tailor it to what the parents need, the foster parents need. We also treat bio parents and work on transitions. We try to encourage the DCFS folks not to pluck kids from one setting to another if there's not a danger present. We try to do planful transitions. Sometimes they go along with us and sometimes they don't.
Does that happen in Romania too? The same sort of
No,
approach?
you should see. I mean, in Romania, we've got kids who've been with the same person for years and years and years. The first placement just lasts for a long time. And, you know, most countries in Europe do not terminate parental rights. Those kids are in foster care indefinitely. There's a lot of institutional care. Like we thought, oh, Romania. And then it's a higher rate of institutionalization in Czechoslovakia. We're like, why didn't we go to Czechoslovakia? But Belgium has a high rate. France has, that's how they wait for the parents to get it together while the little kids are in institutions. Antoine Goodinay had an article in Infant Mental Health about the child protection system for infants in France, and it's just very, and in Romania, they get a little worried that of small children going into foster care. It seems like that's who you'd want to be, you taking care of small children. So anyway, I mean, there's a lot of work to do in this country and elsewhere.
I think we're just out of time here, so I wanted to thank you very much for coming and joining us.